So this lecture complements some of our other COVID lectures. This particular one is focused on non-invasive treatment of COVID-related respiratory failure. So let's take a look at some of the learning objectives for this presentation. They include summarizing the etiology. Etiology is kind of the root cause. The pathophysiology, so once someone is actually inoculated or infected, what happens at the tissue and cellular level. So looking at the etiology, pathophysiology of respiratory failure in COVID patients. We know that many patients that get COVID will not experience any degree of respiratory failure. We also know that there's a select relative few that will develop an element of respiratory failure, and in some of those cases, it will actually deteriorate to the patients needing adjunctive care, intubation, possibly mechanical ventilation, possibly, and some other adjunctive therapies that that are covered in some of our other presentations. We'll also review the general clinical strategies in treating COVID patients. So those are going to include the focus mainly on the respiratory interventions, but we'll cover some of the systemic ones as well, because there's overlap. Something could benefit the patient systemically as well as their respiratory failure. Evaluate non-invasive methods for treating a respiratory failure and COVID disease. There's a little bit of, we talk a little bit about intubation, early intubation versus later intubation. So that's not truly mechanical ventilation, but I kind of stopped just short of the threshold of mechanical ventilation. Describe some adjunctive therapies, summarize some of the gaps in the literature, and probably most importantly is to provide you guys with selected resources that are related to this. I will tell you that the literature is evolving all the time, and just like all of our lectures, including those related to COVID, the lectures will actually morph depending upon the development of the latest research. I furnish you with resources at the end, but I also have included in the body of the presentation some what I call must reads. Okay, so the kind of thing that if you fall asleep during this presentation, et cetera, and you don't really feel like re-listening to it, if you listen to it recorded, then it's sort of thing that you could kind of just go to those slides, take a look at some of the key must reads and go to those, and you probably could extract some very useful information from them. So the etiology of COVID, it's very variable. One of our related COVID presentations done by one of our colleagues, Kenny Miller, it actually talks in depth about the etiology of COVID and some of the theories on, how it originated and how it spread, et cetera. But the etiology of COVID, so the individual is infected. So there's an infection with the new, and it really should be the new family of coronavirus. And it really, the whole notion of SARS is severe acute respiratory syndrome. So we had SARS in 2003. It was a different, if you will, microbe, related but different microbe. COVID was also classified as a severe acute respiratory syndrome of a different, microbial origin. Causes coronavirus 19, really named because of the year in which it was. It started to spread. Virus appears to spread easily among people. That's kind of variable. Early on, it didn't spread as easily, and with the more recent variants. So there's not just the Omicron variant, as is covered in some of our other lectures related to COVID, but there's subvariants. And it looks like as these mutations occur and create these subvariants, the direction, as of this presentation in the middle of 2022, the direction of the mutations have been towards lower virulence, tends to make individuals less sick, not sick, less sick, but is much more communicable. So, spreads much more easily. That has shown that it spreads from person to person, mainly via respiratory droplets, amongst those in close contact. So, 3 feet is better than 1 foot, 6 feet better than 3, et cetera, et cetera. But crudely, a lot of the benchmarks are 6 feet apart. In schools, that's been reduced in many school systems to 3 feet apart, to kind of strike that middle ground of what can be done, what could actually practically be done, at the same time respecting with the guidelines that are out there. The virus then replicates It could also be spread indirectly. Person, touches a surface, another person touches that surface and touches their face. Initially, that was not thought to be a potential cause of significant outbreak, but with the variants, including the Omicron and those, if you will, subvariants of Omicron, the notion that it may be spreading more widely because of indirect contact is being floated around. Pathophysiology, I'm not going to spend a lot of time on this. Many of you either were on the front lines, are on the front lines, supporting people that are on the front lines, et cetera, et cetera. So you kind of know in its worst case what happens. It's a ARDS-like picture. Unfortunately, an ARDS-like picture that does not respond concomitantly or appropriately to some of the ARDS-net guidelines. So some of the guidelines that we've been using for non-COVID ARDS, we absolutely have been using in COVID as well. It's just they seem, generally speaking, not to work as well, and sometimes they simply can't be achieved. Whereas you're looking to try to keep your plateau pressures at 30 or less, patients that have severe ARDS related to COVID, sometimes it's simply not possible. Using very low tidal volumes, compromising on PEEP and things along, using all of the tricks, paralyzing patients, et cetera. It's just not possible. So this slide, you've seen either this slide or variants of the slide, but kind of what goes on after the cells replicate and the inflammatory cascade starts. So you have, both the actual, the infective insult, and then superimposed on top of that, you have all the things that go with an inflammatory cascade. And in its worst form, resulting in, typically hypoxemic, often combined hypoxemic and hypercarbic respiratory failure that's refractory to conventional therapy. Relating to severity, crudely put, of those that that they get infected with the initial strains that presented in 2020, both early and mid 2020, these numbers are pretty realistic. That you had, around 2% of folks died. We're talking worldwide. Okay, so this varied greatly from country to country. And again, one of my presentations that I came up with on comparative responses from country to country to COVID and comparative outcomes talk specifically about the variability from country to country. Lump them all together early on, about a little over 2% cases died, but some cases weren't just mild; they were actually asymptomatic. Not seeing as much of truly asymptomatic cases today, but what you having, cold or flu-like symptoms, and with appropriate intervention that we'll talk about, monoclonal antibodies, some of the antivirals that have been introduced, many hospitalizations are being averted. And then you have your, in-betweens. You have your critical cases, your severe cases that, represent crudely about 20%, 19 or 20%. General strategies, so prevention, social distancing, isolating, quarantine. Today in the United States, there's many individuals. The majority of people, vast majority of people, have actually had COVID. So they're testing positive for the antibodies. It may have been a subclinical case where they maybe thought they had a cold or they were completely asymptomatic. But when they go and they circle back and check these folks, not just a COVID test. But actually checking them for antibodies, many of these people actually have it. The unfortunate part is the nature of this particular infection is that the protection, both from vaccines and from a natural infection, tends to wane pretty quickly. Some of that is because of the mutations that occur. Some of it's not fully understood. So the medications, until recently, the antiviral drugs did not appear to be highly effective at all. Remdesivir was used early on with very limited, I don't want to call it success, but very limited amount of positive side, improvement attributable to it. There's a newer combination, and I will, in a subsequent slide, I'll actually talk about it, Paxlovid, which is a combination of two antivirals that have been around for a while. And it was actually approved by the FDA for emergency use at the very end of 2021. So roughly 6 months ago, give or take. It happens to be a Pfizer drug. I'll talk a little more about it, but that's now, entered our arsenal, if you will. Properly timed steroids are still kind of a mainstay for patients that have moderate to severe disease. And in some cases, the benefits have been dramatic for folks that are really kind of their home, but they really think that they may need to go, to the emergency room, to the hospital, whatever, and they go to a Medi-Center. They get, a dose of steroids, and then a continued, regimen of steroids. And in some cases, it's dramatic. The improvement, it's not a cure, but what gets a lot of these patients isn't just the infective insult. It's really the inflammatory cascade that occurs very quickly, and it lingers for a long period of time. Convalescent plasma is still being used, but the problem is we now have a moving target. So the plasma that we're harvesting from people who were infected, it matters what strain they were in, or strains they were infected with. So you need to be using the appropriate, plasma for the appropriate type of infection the patient has. Monoclonal antibodies are still being used. These infusion centers still exist. If particularly useful or valuable to individuals who are, number one, vulnerable because of their age or concomitant disease, and individuals who are immunocompromised. Folks that are on these medications to, these anti-inflammatory and infective medications. Sometimes people are on medications to help prevent organ rejection, things along those lines, or they have a disease such as multiple sclerosis and they're on, drugs to squelch their immune system because they have an autoimmune disease. MS is an autoimmune disease. Those folks really need to have a plan. If they were to get exposed or actually have COVID, they could succumb to it very quickly. So, one of the pathways that's out there is quickly get them a monoclonal antibody, infusion. Anticoagulants for the 20 or 30% of those that suffer from coagulopathies, that could be very useful. And hydrochloroquine, again, not used widely, but I will tell you there's some studies out there in peer-reviewed journals that really compare the group that got the med versus one that didn't. And some of those really point to a potential benefit. As far as respiratory care, which will be the emphasis of this presentation, low and high flow oxygen, non-invasive ventilation, proning, nitric oxide, and some of our invasive modalities, which I'm not going into in any detail because some of our other COVID-related lectures do that. So this medication, Paxlovid, frankly, I didn't hear about it in December. I heard about it in late January, and I was just keenly interested. So it's an oral antiviral combination, two medications that have been around for a while and approved by the FDA, but not in combo. So they got their emergency approval from the FDA, as I said, in late 2021. It's a combo, these two medications. The administration, as soon as possible after diagnosis with COVID-19. It's 3 pills twice a day for 5 days, and the dosages are shown here. The mode of action for each of the two combo medications are described here, and some of the efficacy data. So released by Pfizer. In order to get the medication approved for emergency use, you still need to show data. It can't be done on a whim. So, Pfizer basically produced data that showed that this treatment with Paxlovid cut the risk for hospitalization or death by almost 90%. The one footnote, if you will, is patients that takes Paxlovid often have to be taken off of other medications, particularly cardiac medications. So the potential benefits of Paxlovid need to be weighed against the risks of taking a patient who has a chronic atrial fibrillation off of their, anticoagulants and other medications. So it's one of those things. It shows a lot of promise, but it's also not a panacea. All right. So now let's really turn our sights to what's in our arsenal from a respiratory therapy perspective, short of mechanical ventilation. I touch on a little mechanical ventilation, but again, we have other COVID-related presentations on that specific topic. There's a lot of algorithms out there for, earlier intubation, late intubation. This is a busy slide. I guess I apologize for it, but it basically has some kind of key steps in it. The management of respiratory failure with either suspected or confirmed, respiratory failure secondary to COVID-19. So, they're defining respiratory failure, P to F ratio is less than 300. Obviously, 100 is a lot worse than 250, but the conventional oxygen therapy, you try them on a nasal cannula. Boris Johnson, the Prime Minister of the UK, Donald Trump, obviously our former president, they both were getting some nasal oxygen. They got a lot of other interventions, and both of them, Trump was only hospitalized for a relatively short span of time. Boris Johnson was hospitalized for a much longer period of time, but they both ultimately responded to low flow oxygen, steroids, and other interventions. And you're kind of working your way down here. Do you keep the patient at 8 mLs per kg versus 6? And a lot of that is determined based on plateau pressures, peak pressures, hemodynamics, arterial blood gas results, etc. And then working your way down. Once you get a little further down after intubation, do you try a neuromuscular blockade? Basically incremental PEEP up to 15. Lions and tigers and bears on mine. Not, different modalities, APRB versus, we're not introducing proning, etc. Again, this isn't a presentation so much on invasive treatments, respiratory treatments. But again, I would be remiss if I didn't at least include a slide that covers the continuum from basically low flow all the way up to ventilatory strategies. Respiratory care algorithm with high flow, non-invasive, versus, a later intubation strategy. And it's one of the controversies that's in the literature. Okay, and I just updated a chapter, Egan's chapter, Egan's Fundamentals of Respiratory Care, a textbook that I now co-edit. And we in the medical gas therapy chapter, we actually talk a bit about high flow nasal cannula, its use in COVID patients, and the potential benefit of using that strategy to avert intubation, but also being wary that patients who are left to hyperventilate, struggle for long periods of time, can do injuries to their lungs similar to what you'd get with over distending because of mechanical ventilation. So they're not intubated yet, but they're breathing hard. The shearing pressures are still there, and they're actually doing damage. And plus they're decompensating otherwise. So, some of the crude guidelines were if the patient needs, to be on, 60-60 or more, or 50-50 or more for more than 3 days, and they have COVID, then it's probably not a good prognosticator. Now that's a kind of almost anecdotal rule of thumb. But this particular piece by Roef and others in 2020 really included another algorithm that's much simpler, and talked more about later intubation and delaying. Again, our arsenal includes the following, as I mentioned: low and high flow, non-invasive, adjunctive therapies that we'll talk about, and then combining them, which, for instance, combining things like, the non-invasive ventilation with proning, or high flow nasal cannula with proning. Little tough to do, but still it's potentially possible. This is one of the must-reads. It published in 2022, and it really kind of looked at non-invasive respiratory support for acute respiratory failure. All right, pretty well done study. I would strongly, again, if you fell asleep during this presentation, or just, don't really want to sit through this, and et cetera, I would say at some point when you come up for air, this would be a good thing to read. Okay. There's a narrative review. So what they did is they looked at a lot of other studies that were done on the benefits and possible harms of non-invasive respiratory support. The key points, which I totally stole from the actual article itself, that first bullet point is maintaining spontaneously breathing patients that are hypoxemic carries a risk of self-induced lung injury. They're working too hard, okay, develop diaphragmatic fatigue, but worse than that, they can actually develop an inflammatory cascade of the lungs because of these shearing forces, breathing so fast, so hard. High flow nasal cannula is most widely applied intervention. That's non-invasive. Helmet, non-invasive, although not approved in the United States. I understand it was occasionally used, was pretty widely used in many other countries with an element of success. Awake prone position is a promising physiologically sound approach as well. We obviously found that some of the patients did and still do start proning themselves. Benefit of averting intubation by means of non-invasive should be balanced with the, with the potential harm that's out there. So those are really the key points of this article. They go into a lot of detail. It's probably, worth reading if you have the time. Low flow oxygen, I said before that should certainly be part of our arsenal. Any of you who are or have done, home care during COVID times, if you work on, with EMTs, paramedics that were bringing these patients in, that, low flow oxygen was certainly, in our arsenal. High flow, a little bit more granularity on it. So basically looking at patients that have mild to moderate hypoxemia. Devices would include a non-rebreather and high flow nasal cannula. For a while, we were actually using a nasal cannula and non-rebreathers, and there was varying opinions in our organization. So in addition to working with Terry and teaching at Rutgers and a lot of other stuff, editing textbooks, I still work at the bedside, and actually was a full-time adult acute care respiratory therapist up until 2 months ago, something along those lines. Still work at the bedside though. Advantages: may avert intubation, easy, relatively simple setup. Everything is simple if you have the equipment, but if you ran out of high flow nasal cannulas, then it's not so simple. Disadvantages: may delay but not eliminate intubation mechanical ventilation, especially in those with moderate to severe disease. A false sense of security. I tend to be more in favor of giving it a shot, by the way, just to be abundantly clear. Periodic checks needing, basically, risking the clinician exposure. So it's not just checking the patient, making sure the water bottle's filled, if they're on treatments, filling up their treatment and things along those lines. Some hospitals were actually limiting flows to 30 to 35 liters rather than going up to 60. To reduce, the theory was, theoretically reducing clinician exposure. And then there's actually this one study, and again, I refer to studies throughout this presentation, but Jing Gang and others published in 2020 found that high flow, in bold here near the bottom, high flow may be effective for COVID-19 patients with mild to moderate hypoxemic respiratory failure. Again, should certainly be one of the considerations. But again, it needs to be weighed. The risks to the patient, the risks to the clinician taking care of them should be weighed. ROX index is not specific to COVID, and if you guys are totally aware of what ROX is, that's cool. That's a good thing. It's a useful indicator that can be used even in non-COVID patients. So the ROX index, and its descriptive ROX index, is the ratio of pulse oximetry to FiO2 to respiratory rate. Now, I'm going to go over an example, so just hold on to your horses there. The acronym ROX stands for respiratory rate and oxygenation, okay? And a crude cutoff, ROX index of 4.88 or more, okay? So 4.88 or more, higher is better. Just to be clear on that. So a ROX index of 4.88 or more measured after 12 hours of high flow was associated with a lower risk of mechanical ventilation. I'm one of these people that I hate these, hard and fast cutoffs, 4.88, what if it's 4.89 type of deal. It's to give you a guideline. Okay, the upper fours, if it's higher than the upper fours, then, after 12 hours of high flow, so, associated with a lower risk of mechanical ventilation. Lower than, the upper fours, then that risk, becomes, as lower you go, it becomes, it becomes a greater risk. Prediction tools, so it's mainly used to predict, and monitor patients on high flow devices, can be helpful in, predicting or helping predict success or failure with the use of high flow nasal cannula. It should be monitored at least per the guidelines that are out there at 2, 6, and 12 hours. Doesn't mean you can't do one at 4 hours. It doesn't mean that, but they're saying you want to also determine whether or not it's staying the same, it's relatively static at a decent number, or if it's, getting worse and getting lower and heading in the wrong direction. A trend of a score dropping is a potential sign of failure and consideration of a different mode of ventilation and oxygenation, obviously. A quick example here, the formula, SAT over FiO2, both of those, divided by respiratory rate. The example I give, if the SAT's 90, the FiO2 is 70, the respiratory rate is 30, okay? In this particular example, doing the math, you come up with a ROX in the low fours, okay? So you think about it. Patient's SAT is 90, FiO2 needing 70, okay? And the respiratory rate's 30. The respiratory rate's high, so those aren't horrible numbers. I don't like the FiO2 of 70, by the way. They're not horrible numbers, but you can see that the resulting ROX score is beneath or below the 4.88 threshold or guideline threshold that's out there. So this patient, compared to a patient who was 5 or 4.9 or 4.8, the 4.28, they would be at greater risk for intubation. Some of the research now specific to COVID-19 and high flow, Chandel in 2021. This was a retrospective review, so it wasn't a prospective study. This is one where they went back in the electronic health record and they took a look at various indicators, and this related to high flow. And they determined by looking at the chart, the medical record, that high flow was deemed to be a viable strategy. That some of these patients did very well, and in fact, we seemingly averted mechanical ventilation and intubation in 60% of these patients. In the minority, some of them did progress to mechanical ventilation. The duration of high flow, so you kept them on longer, was not associated with worse clinical outcomes. Okay, so it wasn't like so it was just something to think about. This statement, duration of high flow was not associated with worse clinical outcomes, is a finding, but you'll find that there's some other studies that don't necessarily say that. So, you look at one study, it says one thing. In some cases, other studies will contradict. And the key is to look at the strength of the studies and kind of weigh, how many studies and how strong were they and things along those lines. In this particular study, the ROX index was sensitive for the identification of individuals who could be weaned off of high flow without being intubated. Okay, so that kind of a secondary outcome. Number one, high flow is a viable strategy. Number two, ROX index can be a viable tool to help predict whether or not these patients are going to fail high flow and need intubation. Vega in the Journal of Pulmonology 2022, multi-center retrospective observational study. So this was one that wasn't a chart review. They actually planned the study and then they executed it with specific aims and hypotheses. The findings were the ROX index may be useful in guiding clinicians, also demonstrates a different threshold than reported for non-COVID patients. So there is some theory out there that threshold for COVID patients can be higher, well into the 5s, almost 6 for COVID patients. So it's not, I'm not saying that you should definitely use that, but you need to be aware that this particular study did show that the threshold of 4.88 may not be appropriate, and that a slightly higher one would be used for folks that have COVID-19 respiratory failure. Non-invasive ventilation. So, this particular study that was done by Honore and Gutierrez and others, COVID-19 patients with moderate hypoxemia, hypercarbic respiratory failure, and a prohibitive breathing pattern. Respiratory rate was, well greater than 30 for a sustained period of time. The advantages may avert intubation and mechanical ventilation. Okay, may delay but not eliminate. Okay, so it's one of these, well, it may not type of deal. The point of it is it really suggests that non-invasive may have a role. Okay, non-invasive ventilation, that is, but basically looking at it in comparison to high flow. So non-invasive often needs less maintenance, if you will. You're not going in the room as often type of deal. I don't know that I totally agree with that, because some patients, as we know, will pull on their non-invasive masks or interface and dislodge them, and you got to go running in the room and that sort of thing. But they're really just pointing to one versus the other, and they're really saying that non-invasive and high flow both have advantages and disadvantages. Helmet, CPAP. So, this is something, again, not yet approved in the United States, widely cited, widely used outside of the US. And this particular study that was a case series in a Canadian hospital pointed to, that the non-invasive helmet provides an alternative interface, and that the helmet interface may reduce the risk of virus exposure. That you're now containing, that you're containing it, and the exhalation port with a filter, but patient may still be coughing and lifting up the mask and things along those lines. If they actually have a helmet on, there's less risk of that sort of stuff. They could still theoretically, try to pull the helmet off, but it's much more difficult than simply taking off, a full face mask or nasal pillows or whatever. Non-invasive, a little more on this. So this is really, I put this slide in here because this is really talking about multiple studies. Okay, Magna and others, 2022. And in the interest of time, I want to just kind of cut to the chase on some of these as I review these studies. But Magna basically found that non-invasive respiratory support and awake prone positioning are both tools. So combining the two is a potentially viable strategy. Also found that careful monitoring during any treatment is warranted to avoid any delays in endotracheal intubation. So, for instance, having an evidence-based protocol where if the other indicators, respiratory rate, etc., but things like P to F ratio are starting to decline rapidly, the patient's mentation and ABGs are declining, then it's not, making sure you don't wait too long. Glendardi also in 2022, it was a meta-analysis, and all I'm going to say is meta-analysis combines the results of multiple studies. So meta-analyses that are very well done, and they adhere to what's called these PRISMA guidelines, throwing a lot of acronyms at you. But basically, if you see a meta-analysis, they follow PRISMA guidelines, particularly if it's one that's been published in Cochrane, okay? It's probably something you need to read and pay attention to, because they're combining the results of multiple studies. So patients treated, these guys found it, patients treated with high flow showed better outcomes compared to non-invasive. Therefore, high flow should be considered. Now, again, I'm not saying this is gospel, but it's something it's treated as relevant, potentially useful information, okay? NAIR in 2021, so when the preceding year is published, so randomized control trial of high flow versus non-invasive, and the 48-hour intubation rate was similar. Now, with these studies, when you're comparing high flow and non-invasive, the problem is which patients were truly sicker. So trying to normalize, or regulate the playing field or level the playing field can be a very difficult thing to do. But this particular study, intubation rate 48 hours are similar. Intubation rate at day 7 was lower for high flow, and hospital mortality was similar. So it's something to kind of just keep your ear to the tracks on. Another must read, okay, CHEST in 2020. So this is a busy slide. I'm going to apologize, but I'm not going to apologize. The significance, and I really encourage you guys to read this, because it really illustrates, there's a table, and this is just an excerpt from a table that's in this study, where they compared the if you will, we have the American Thoracic Society, ATS, okay? In Europe, they have the European, Thoracic Society. In other countries, they have different, different societies of a similar, with similar aims, okay? And the significance of this article is they really looked and said, okay, well, and I'm going to go, so in Argentina, very, very top one, the Association Argentina Medicine Respiratory, blah, 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 okay? High flow nasal cannula, they're pro, and they're pro non-invasive, okay? Just to be clear on that. Interestingly enough, the American College of Chest Physicians, all the way at the bottom of this particular slide, is basically saying they have no recommendations on high flow, and they have no, basically say regarding non-invasive careful use, all right? So this article is really, useful because you can see the variability of countries in their positions and their professional, if you will, I'm going to call it pulmonology organizations. In Ireland, right in the middle of the slide in white, okay, the Irish Thoracic Society, they're pro high flow, okay, they suggest that they keep the flow to about 30 and that it be done in a negative pressure room. Okay, they're also pro non-invasive, and they suggest that a helmet be used. All right, so it's just different countries are doing different things. The scary thing is probably for different reasons. Okay, and some of them, as you could see, American College of Chest Physicians early on had no real opinion on high flow, which is very, very interesting. At our facility, I've said this in other related lectures. In our facility, we did not start using high flow until December of 2021. So we were almost 2 years. We were, 1 year and 8 or 9 months into this pandemic, and we finally started using high flow in a sort of a trial basis. That's a rabbit hole I'm not going to go down in right now, but suffice to say that. Adjunctive therapies, so looking at prone positioning and inhaled pulmonary vasodilators. So let's talk a little bit about them as well. So prone positioning, before I get into the nuts and bolts, it's a viable tool. Let me just say that much. The benefits need to be weighed against the disadvantages, but they're aside from, and they're not innocuous, but tube dislodgement. And we're really talking about breathing tube, but it could be line dislodgement, IVs. And for these patients, that could be a death sentence. The loss of an endotracheal tube, the loss of IVs could be a death sentence. So if that's properly accounted for, okay, there's not a ton of downside unless the patient is very unstable and they're apt to code. Because the last thing you want is a patient's in prone position and they code. You need to flip them, by the way. You're not doing compressions on their back, which also means you're going to need to get their, they have the leads. When they're in prone position, they have the leads on their back. So they're going to need to be flipped, and they're going to need to be flipped in an orderly fashion so you don't lose your airway, you don't use your lines or ports, drains, you don't lose any of those things. And at the same time, you're doing so, you're flipping the leads, and the pads for the EC or EKG, and needs to be done quickly so that you can start CPR type of deal. Okay, but save for that, aside from that, a very, very viable strategy, which can be combined with both non-invasive or high flow or invasive therapies. And this particular article done by Damala and others, published in 2020, really looked at patients that are prone, and many of you have probably seen this. You prone a patient, you do a post-hour or so post-proning, you do an ABG on them, and their oxygen will often nicely improve. You leave them prone, just to be clear on this, you leave them prone for a minimum of 12 hours. A lot of places where you're doing 16 to 18 hours, and then supinating them for 6 hours and then flipping them back over, type of deal. So do not, unless the patient does not respond well to the proning, and you can flip them back. But if they respond to it, or even just are holding their own, they don't respond poorly, leave them, in that position for a minimum of 12 hours. That's what the latest data says. Oxygenation will rapidly improve in some of these patients. The key is it's really it's the ultimate recruitment maneuver. Okay. Patients reported improved dyspnea, the spontaneous breathers. 7 of 10 patients did require escalation of respiratory care, and 8 of the 10 did not require intubation. So, it's just one of those things that you just got to kind of keep in your arsenal, be aware of the disadvantages, but keep in your arsenal. So to kind of build on this a little bit, adjunctive therapies, you could be proning your patient, particularly if they're mechanically ventilated. But you can also introduce adjunctive inhaled vasodilators. Let's talk a moment or 2 or 3 about them. So inhaled INO, inhaled nitric oxide in COVID. So Parak and others looking at inhaled nitric oxide in spontaneous breathers, which is the emphasis of this presentation. Case series looking at 39 spontaneously breathing patients with moderate hypoxemia in COVID-19, finding that of the 39, a total of 21, so 54 or so %, did not require invasive mechanical ventilation after treatment with INO. Okay, and again, if you look at what percentage of those patients that got moderate hypoxemia that needed to be intubated, it was probably well in excess of 50%. Okay, so in this case, 54% did not require. Of the 21 patients, 20 were successfully discharged, but there was one death. So some of the significance or discussion, INO therapy may have a role in preventing the progression of hypoxemic respiratory failure in these particular patients. So may have a role. Nicolay in 2022 did a review of the current literature. And something to keep in mind with inhaled nitric oxide is that it's not just a potent pulmonary vasodilator. It also does have some antimicrobial or antiviral effects or characteristics. So, there's some cases out there, and I didn't want to go down this rabbit hole for this presentation, where higher than 20 parts per million were used. And it looked like some of the outcomes were particularly interesting. Whereas the studies that were done back in 2000-ish, something along those lines, that looked at inhaled nitric oxide, it was determined pretty much when you go north of 20 parts per million, there's not an added benefit. And at the time, there was the added drawback of producing nitrogen dioxide and just other bad concomitant results from it. It's also the anti-inflammatory properties. So inhaled nitric oxide also has some anti-inflammatory properties. And it's theorized that may have offered some secondary benefit in addition to the pulmonary vasodilation. So the key was early administration of inhaled nitric oxide may be effective. There was a hospital out in the end of Long Island, actually in the Hamptons. So for any of you folks that aren't from this area, so you got Long Island, and all the way to the tip of Long Island, you have the Hamptons, and at the very tip, you have Montauk. So the Hamptons are a very wealthy area. And there was a hospital where they used a ton of nitric oxide. They used it quickly. And the people, honestly, they got it. They wanted it. They got it. They were willing to, donate money to the hospital, whatever. And the outcomes there, one site, the outcomes there were pretty damn good. So it's anecdote. They did not turn it into a study, into research study, but just kind of read, and I have enough network like a lot of you guys do, and basically they turned around and said there might be something here. So just to kind of keep, I'm not saying that you should overuse this stuff, whatever, but it was used. Inhaled nitric oxide still is used. Still, some of the places are now saying, let's give it a whirl. If there's no significant benefit or positive response in the first let's say 2 to 12 hours, then let's ditch it. Let's not go down with the ship on that. Inhaled Flowline or epoprostenol. Okay, and this was used less commonly because here you had syringe pumps, and you had to put the actual syringe pump on the proper setting. If it was being weaned, you had to make adjustments to it, et cetera, et cetera. So it was kind of one of those things that was a little bit difficult to, to actually manage appropriately, but it was used. So, a review of this one that was done by Renier and others, it was reviewing the pharmacological therapies in treating mechanically ventilated COVID-19 patients. And they basically determined that Flowline should be considered in cases of refractory, oxygenation issues, oxygenation respiratory failure. Keep in mind that anybody that's worked with Flowline, and I'm sure that a lot of you have on mechanically ventilated patients in particular, is that the glycine buffer is sticky, and you need to be replacing the expiratory filters. So it requires some maintenance. It requires going in rooms, maybe more frequently than you would if the patient was not on Flowline. Other medications and modalities that were out there, some of which I touched on as we got started here. So bronchodilators, short-acting beta adrenergics such as albuterol. What we ended up doing was, just also because we wanted to limit the amount of times going in and out of the room. And we also know that albuterol can be an overutilized medication. There wasn't any of this, well, we'll just give them albuterol because it may help them. It was no, unless they were actively wheezing or there's an indication for it, albuterol treatments are PRN. The patient was clearly showing there's significant auto-peeping or significant bronchoconstriction, wheezing, et cetera, then we might introduce it. Mucolytics also were used sparingly. We found that the mucus in the COVID patients that had respiratory failure was some of it was, sometimes it was thin, sometimes it was thick. It was very variable. So, it was in the arsenal, but not commonly used. CPT via the bed was also in the arsenal. PEP therapy, particularly things like metanebs, were not used that widely because of fear that it could spread the actual infection further. Sedation with mechanical ventilation. So that was mechanical ventilation was, used in extreme cases. Those patients were sedated with medications like Versed and Pro. Targeted a RAS to keep them pretty deep of -3, -4. And in further extreme cases, patients that were on mechanical ventilators, as some of my colleagues said in other related lectures, not only were they sedated, but they would also sometimes be chemically paralyzed in order to facilitate ventilator synchrony and reduce ventilator pressures. Some benefit was out there to combining these strategies, prevention, mitigation, systemic treatments, vaccines. Again, my colleagues and other lectures related to COVID talked about vaccines. Scary thing, I guess it's scary, is that initially some of the vaccines were 90 to 95% effective in preventing hospitalization. And now that number has gone down considerably, but that's the bad news. The good news is that some newer vaccines are being introduced that are seem effective against some of the variants. Antibodies and steroids as well. And then on your spontaneously breathing patients, where it comes to their respiratory care, oxygen therapy can be combined with pulmonary vasodilators and further combined with things like proning. So you got choices there as well. Thankfully, with the lens through which we need to look at this is, at least for now, the virulence. Again, much more contagious, much less virulence. Virulent is how sick the actual these variants can make you. If non-invasive, the timing of intubation of these patients. So, again, this is not primarily emphasizing mechanical ventilation and intubation, but that's, the threshold that we pass when we go from spontaneously breathing to an artificial airway. Some COVID patients are remarkably tolerant of moderate hypoxemia. On their cell phones, Satin 87, breathing around 30. They're on the cell phones, they're waving to you. How you doing? How you doing? I'm doing good. How you doing? But some of them weren't. But some of them were. They were until they weren't. So they would be there, and then all of a sudden, when they frump, they tended to frump. Frump as in decompensate. Some patients who were tolerant of hypoxemia quickly decompensated. This caused the timing of intubation of these patients to be questioned. And Hernandez, Ramayu, that's actually one individual, 2020, retrospective cohort study of over 230 patients. They were admitted to the ICU COVID-19. Mortality did not differ by timing of intubation. Less than 8 hours, 8 to 24, greater than 24 hours, did not differ. Lee and others in 2020, also retrospective multi-center, 39 patients, early intubation was not associated with improved survival. It's controversial because there are a few studies out there that say it can offer some advantage, and you don't want a patient to be injuring their lungs because they're breathing so hard and fast and creating those shearing pressures. These are two studies that said otherwise. So minimizing clinician risk. So the big deal is particularly early on, one of the other lectures I give on COVID, is a view from the front lines. And, one of the things now, but particularly early on, was the fear that not even knowing how contagious this is, how sick it can make you, am I taking this stuff home? And, we all were, if you were in the front lines, you were, whatever, taking your gear off in the backyard, in the garage, in the tent you set up, and, freaking March, you're out there shivering your butt off. You did what you needed to do because you didn't know, you didn't want to bring this stuff into the house. Having your wife, your husband hose you down in the backyard, whatever. It's crazy stuff. Now we had to have at least a somewhat better understanding of, how it spreads and things along those lines. So some of the things that we really, very mindful of as we became more conversant and aware of some of the realities of COVID. And they were actually published by Zanjura In 2020, some of the measures that can and should be done: negative pressure rooms, using a PAPR at a minimum of N95. Properly fitting N95 can be as nearly as effective as a PAPR. The problem is again, properly fitting is the key. And do they have the N95 that you need, that you've been fitted for? High flow patients should wear a mask. So the patients, perhaps consider keeping high flows, the maximum flow to 30-35. Avoid using BiPAP mask with an exhalation port on the mask itself. So something you can put a filter on. Again, placing the filter on the exhalation port, etc. Placing a filter. We really didn't do a lot in terms of manually ventilating these patients with an AMBU mask back. When we did it, we put a filter on there, but that was something we discouraged. We put them right in the ventilator to the extent that we possibly could. And then some of the other measures are indicated there as well. More work to be done. That's life, right? Discovered about COVID, the transmissibility, the newer variants is higher, really should say much higher. Pathophysiology, why some are asymptomatic or very mild disease and others are so vulnerable. It's still somewhat of a mystery. We understand some of the risk factors, but it's still a mystery. Treatment, many therapies are only marginally effective, although we're getting better in that area too. Prevention, I have the vaccine question mark because they're still the standard of care as long as they're not contraindicated, but not as effective as they once were. Many articles were rushed into publication early on and had to be retracted. Many articles are smaller, less scientifically rigorous, but that's changing as time goes on. Some research studies contradict others. Vaccine efficacy is waning. It's, just some scary stuff out there. Clinical strategy be combined to produce a synergistic effect. We're seeing some of that, but are there other blind spots that we need to try to shed the light on? What are the longer term impacts on our healthcare workforce? And I talk about that in another presentation that relates to the impact of COVID on the healthcare workforce. Something that's probably an under-examined area and certainly under-addressed. Some selected references are here, including several of the references that I had in my other, just that I've cited throughout this presentation and that will appear in some of the other related presentations. So with that, I want to thank you all. Hopefully you enjoyed this presentation as well as the other presentations that relate to COVID.